patients and clinician perspectives on autoimmune encephalitis. We have 4 presenters today. The first is Susannah Callan, who is a reporter for the New York Post, who has written an extraordinary memoir that has been on the New York Times bestseller list called Brain on Fire, and she is going to read today from her memoir. We also have 4 Duke doctors who are going to be presenting and talking briefly and then having a discussion with Susannah and with the audience about autoimmune encephalitis. The first is Dr. Bill Galentine, who is a pediatric neurologist, and Heather Van Matter, who is a pediatric rheumatologist. Dr. Galentine and Dr. Van Matter are co-directors of Duke's Children's Autoimmune Brain Disorders Clinic. We also have a colleague from the Department of Psychiatry, Xavier Prudhomme, who is a psychiatrist and an internist who has treated many adult patients with autoimmune encephalitis. Susannah will first read from her memoir, and then our doctors will present, and then we're going to have ample time for questions and discussion. In addition to Susannah, we have with us today other patients and families who have been affected by this illness, and I want to introduce them. I'm going to start with myself. I am the mother of a child with autoimmune encephalitis. Excuse me for being emotional. And my husband Daniel is here today. Our son first became sick at age 13, and the 3 physicians who are presenting today, along with other physicians and nurses and social workers and people at Duke, have been part of what we call Team Sasha, which has enabled our son to today be taking 11th grade courses and getting A's in them. I also want to welcome 3 other families who are here who also have children with autoimmune encephalitis. They're all sitting over together on that side of the room. The first are Will and Leslie McDowell, whose daughter Florence first became ill with autoimmune encephalitis at age 2.5. She had 2 bone marrow transplants. Florence McDowell died on March 4th of 2012 at age 6. Brian and Jennifer Whittington, their daughter Ellen, who has autoimmune encephalitis, and their daughter Jenna are here with us today. Ellen was first diagnosed with autoimmune encephalitis in December of 2011. We also have with us Deborah Kanan, whose family has moved temporarily from Miami to, so that their son Sammy can be treated by the clinic that Dr. Galentine and Dr. Van Matter are leading. So here, people in the audience and in thinking about this presentation today are all people who are part of Team Florence, Team Ellen, Team Sammy, and Team Sasha. The goal of this Grand Rounds is to tell the stories really through Susannah being our voice about this illness, but it is also what we think of as our beginning of a call to action. With the leadership of Leslie and Will McDowell, we are coming together as families and doctors and have founded a foundation called the Autoimmune Encephalitis Alliance. The goal of our alliance is to make Duke and other medical centers of excellence in the treatment of this illness and in the finding of a cure for it. Our goal is also to provide support for families so that nobody has to fight this devastating illness alone. To this end, I want to introduce 2 videographers, Elena Rue and Catherine Orr, who are going to be filming today and with the permission of our families, because we are working to make a film, a short film, to be able to explain this illness, not only to colleagues at Duke, but to everyone around the world. They will also be filming at the Alliance's first fundraising event, which Will and Leslie have organized in honor of Florence. It's called Florence 4th, and it's a race, a 10-mile race for those who are really good athletes. And then a 5K run walk for everyone else. It's going to occur on March 2nd, starting on Duke East campus. And we encourage anyone who wants to be part of that event to take part. And we'll have the website up on our last slide about how you can sign up. So let's begin.
So in 2009, I started acting erratically and out of character, and it started very subtly, just with some paranoid thoughts, and nothing that I thought I needed to go to see a doctor about. But then things started progressing and getting worse and worse, and I had a seizure, one of many, and I ended up in the hospital for a month where I was ultimately diagnosed with what's called anti-NMDA receptor autoimmune encephalitis. So that's kind of the backstory, the quick backstory. I'm going to read 2 chapters from my book, and there are different phases in the illness. The first I'm going to read is an example of my psychosis during the height of the disease. And that was when I had been in the hospital for about 5 days. At that point was the height of that psychosis period. And the second piece I'm going to read about is actually the step towards getting an ultimate diagnosis, the first step that led me to finally getting the diagnosis that I got. So I'm going to start here. Okay. Later that same day, a 5th doctor joined the team. My case had piqued the interest of Dr. Ian Arslan, a psychopharmacologist who topped 6 feet and who looked more like an aging hippie than a doctor. Because of his fondness for Beat Generation writers and his cerebral way of communicating abstract medical jargon, a colleague described him as a walking beatnik dictionary. He had already heard about my escape attempts and paranoid delusions, so he approached my mother first, asking her to walk him through the past few weeks of my bizarre behavior. Then he interviewed my father. After a short interview with me, which yielded a vivid portrait of my dysfunction, he gathered statements from the nursing staff and even called up Dr. Bailey, who had been a neurologist that I had seen prior to my hospital stay, who told me that I was suffering from alcohol withdrawal. Who, according to Dr. Arslan's notes, told him that I drank excessively up to 2 bottles of wine per night when I had told him that I had 2 glasses of wine per night. Dr. Bailey's estimate of my vices seemed to have substantially increased. Having summarized all of this, Dr. Arslan jotted down the 2 diagnoses he wanted to rule out: postictal psychosis and schizoaffective disorder. Knowing it would upset them, he did not share the second diagnosis with my parents. The term schizoaffective disorder was introduced in 1933 in a much-quoted paper, The Schizoaffective Psychosis. Quote, like a bolt from the blue, full-blown delusions suddenly shatter the poise of a fully rational mind and flare up without any premonitory signs. A more updated description defines it as a diagnosis when mood symptoms, which are characteristic of bipolar disorder, overlap with psychosis, which is symptomatic of thought disorders like schizophrenia. So I have an EEG video. Since I was on the epilepsy floor there were actually videos taken of me, and I have an EEG video, and I'm going to describe that video here of myself. This is EEG video, March 24th, 11:06 p.m., and it's 11 minutes long. Patient push button in room 1279. Patient push button in room 1279, the pre-recorded voice says. My hospital gown peeks through from the covers that are pulled up to my neck, and I hold a cell phone to my ear, talking animatedly into its mouthpiece. It is unclear if anyone else is on the other line. I pick up the hospital-provided TV remote and speak into it. There is certainly no one at the other end of that conversation. I point to the camera accusingly, gesticulating wildly, and put my hands to my head in frustration. Oh my God, I cry and hit the nurse's call button. Can I help you? A nurse says over the intercom. No, it's okay. Ma'am, lady, miss, I'm coming, another nurse chimes in. I'm mumbling to myself now. I don't know what's happening. I'm going to turn my phone off. I toss my cell phone to the foot of the bed. A nurse arrives with some pills, and I swallow them without hesitation. I can't have it on me. I'm on the news, I shout. The nurse answers, but too softly for the video to pick up. I begin to shout and kick my legs, and I grab for the nurse's call button. Please, 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 I'm freaking out, I'm freaking out. Patient push button in room 1279. Please put the TV back on, I shout. Please put the TV back on. Ignoring my outburst, the nurse positions the guardrails to make sure they're firmly in place. Don't you see I'm on the news? I'm on the news, I howl. I pick up the TV remote and speak into it again, and then place my head in my hands and rock back and forth. Please, 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 oh my God, please get me a doctor, please get me a doctor. The nurse leaves. There is a flushing of toilets. I stare straight up at the ceiling as if I am praying. That's the end of the video. So I remember a little of this hallucination, and so this is my memory of that. Was the objective video. This is what I remember. We'll be investigating what's happening with news reporter Susannah Callan, currently at New York University. A coiffed female anchor announces, I am top of the hour news. I'm on the news, I call out. Her father was recently arrested for the murder of his wife. The anchor says as the camera pans my father walking handcuffed through a sea of paparazzi. I've been so stupid I shouldn't have answered calls from coworkers. They are secretly writing down what I'm saying. They know I cried in the newsroom. They'll put that into my story. New York Post reporter unravels after father kills wife. I'm on the news. I grab the emergency nurse's call button. They have to know about the plot. They have to know not to let anyone in. They're all going to try to interview me, I scream into my cell phone. Beads of sweat form on my brow. I wipe them away. I hear the cackling of the patient to my left, a South American woman who spent all day chatting with her visitors in Spanish, or was it Portuguese? Now she's laughing at me. Maybe she was laughing at me the whole time. I hear her fake fingernails tap on her cell phone keys. She's speaking in Spanish, or whatever language it is, but now I can understand it. There's a girl from the New York Post in the bed next to me. I'm going to record her with my cell phone, and I'll give you the information, and you can give it to the Post. Tell them it's an exclusive from someone in the hospital. This girl is crazy, trust me. Trust me, this is good stuff. We can make a lot of money with this scoop. Tell them everything, just make sure we get some money out of it. Psst, what the hell was that? Psst, I hear it again. I turn my head to the left. The South American woman has stopped her maniacal texting and has moved the curtain with her hand so that I can see her face. The nurses here are bad news, she says softly. What, I ask, not sure if I heard her correctly or if she spoke at all. Shh, they can hear you, she hisses. The nurses here aren't right. I don't trust any of them. Yes, yes, strange Spanish lady, that is true. But why is this undercover agent telling me this, I think? She moves the curtain back in place, leaving me alone. I need to leave, now. Once again, I grab the wires on my head, handful by handful, pulling them out with chunks of hair, and throw them on the floor. Instantly, I'm at the door. I'm through it. My heart pounds. I can feel it leaping into my lungs. The security guard doesn't notice me. I sprint to the red exit sign. A nurse runs up beside me. Think, Susannah. I dodge into the hallway and run, racing, directly into another nurse's arms. Let me go home, let me leave. She takes me by the shoulder. I kick her, screaming. I bite at the air. Let me go. The cold floor. A purple lady grabs hold of my feet as the other nurses hold my arms down. Please, please, I try to say through clenched teeth. Please let me go. Darkness. At the interval history that they took that day reads, patient became very agitated last evening. She ripped off her electrodes and ran past the one-to-one up and down the hallways. This occurred despite receiving Seroquel. She was then given Ativan for agitation and placed temporarily in a chest posy for safety by an on-call resident. She also received 25 milligrams of Lopressor yesterday early evening for elevated blood pressure and tachycardia. Vitals were ordered. Okay, and then this is about 3 weeks later. Now in my hospital room, Dr. Suhail Najjar crouched down beside me and said, I will do my best to help you. I will not hurt you. I didn't say anything, looking emotionless. Okay, let's begin. What is your name? A considerable pause. Susannah. What is the year? Pause. 2009. He wrote down monosyllabic. What is the month? Pause. April. April. I struggled here. He wrote down indifferent, meaning apathetic. What is the date? I looked forward, showing no emotion. Saying nothing, not blinking, he wrote down paucity of eye blinking. I didn't have an answer for him on this one. Who is the president? Pause. I raised my hand rigidly in front of me. He wrote, stiff-bodied on his chart. What? No emotions, nothing. Who is the president? He noted lack of attention span. Oh, Obama. He wrote low tone, monotonous, with a substantial lisp. I was not able to control the movements of my tongue. He removed a few tools from his white lab coat. Using a reflex hammer, he tapped on my kneecaps, which did not jerk forward the way they should. He shined a light into my eyes, noting that my pupils were not properly constricting. Okay, now touch your nose with this hand, he said, touching my right arm. Stiffly and robotically, I raised my arm and in several slow-moving motions, reached my hand to my face, narrowly missing my nose. Hellishly catatonic, he thought. Okay, he said, testing my ability to do a two-step command. Touch your left ear with your left hand. He grazed my left arm to indicate right from left, doubting I could figure it out on my own. I didn't move or react. Instead, I just sighed. He told me to forget about this step and moved on to another. I'd like you to get out of bed and walk for me. I dangled my feet over the edge and slid haltingly onto the floor. He took my arm and helped me stand. Will you walk a straight line, one foot after the other, he asked. Taking a minute to think it through, I began walking in short spurts, but with delays between steps. I angled toward my left side. Najjar noticed I was showing signs of ataxia, a lack of coordinated movement. I walked and talked like many of his late-stage Alzheimer's patients. And then he had an idea, the clock test. Although developed in the mid-1950s, the clock test had been entered into the DSM in 1987 and is used to diagnose problem areas of the brain in Alzheimer's, stroke, and dementia patients. Dr. Najjar handed me a blank sheet of paper that he ripped out of his notebook and said, would you draw a clock for me and fill in the numbers, 1 through 12? I looked up at him with confusion. As you remember it, Susannah, it does not have to be perfect. I hesitated. He could see me straining to remember what a clock face looked like. I hunched over the paper and began to write. Methodically, I wrote the numbers. Often I would get stuck on a number and draw it several times. More perseverative dysgraphia. After a moment, Dr. Najjar looked down at the page and nearly applauded. I had squished all the numbers, 1 through 12, onto the right-hand side of the circle. It was a perfect specimen, with the 12 o'clock landing almost exactly where the 6 o'clock should have been. Dr. Najjar, beaming, grabbed the paper, showed it to my parents, and explained what this meant. They gasped with a combination of terror and hope. This was finally the clue that everyone was searching for. It didn't involve fancy machinery or invasive tests. It required only paper and pen. It had given Dr. Najjar concrete evidence that the right hemisphere of my brain was inflamed. Her brain is on fire, he told my parents. They nodded, eyes wide. Her brain is under attack by her own body. Thank you.
What we're going to try and do here over the next 10 or 15 minutes is just to kind of give a broad overview of this particular disorder, to give you a sense of things that you need to be looking for, and just walk away with just a few major take-home points. We're not going to try to attempt to get into the nitty-gritty of the pathogenesis of this, but we just want to have certain take-home points that's going to help you recognize this particular disorder and know how to proceed from there. So Joseph Daumal is the physician that's actually not necessarily discovered, but actually has discovered the antibody for NMDA receptor encephalitis. And so he published 577 cases of this now, accumulated over about 5 years, and actually showing now follow-up of up to 2 years with some of these patients. And so this is the largest cohort published, and what he very nicely does is show you the presenting symptoms of folks with this. And one of the things that's most striking with this is that it can really affect all age groups. You can see children, the range of this study was anywhere from 8 months all the way up to 85 years. And although the predominant group are female between the ages of 12 and 45, there is a spectrum that you can really see over all ages. When you look at adults and children, the initial presentation oftentimes is going to be a little different, with adults predominantly presenting with psychiatric symptoms. And as again you saw in Susannah's story, psychosis can be a major presenting symptom in that, and that these folks often will have very vivid hallucinations, paranoia, irritability, confusion, and so the psychiatric symptoms can be very, very striking. But along with that, you often will see things turn a little bit, and they often will develop other symptoms that will kind of oftentimes serve as a clue that something else may be going on. Now, these other symptoms actually often are the presenting symptoms in children, and so particularly seizures and movement disorder are very, very prominent symptoms in the pediatric population and often present first, whereas in the adult population, the psychiatric symptoms are often the first symptoms to present. That being said, if you look at all of these symptoms over the course of a month, by that 1 month mark, at least 4 of the symptoms that you see listed on the slide here are present in almost 90% of the patients. And so there are some things that we can really think to focus in on in terms of looking at the symptoms that can kind of help us maybe identify these patients from other patients with psychiatric illness. And so the predominant factors that we talked about are behavior, but also cognition. So drops in their cognitive performance is definitely seen. Memory deficits, language regression. So is often a big one that you will see, not only perseveration, but particularly even progressing to aphasia, where they actually have loss of speech completely. Seizures are prominent, and there are multiple different seizure types that have been reported in terms of partial onset seizures, generalized seizures, myoclonic seizures, all varieties. And movement disorders is very prominent as well, which can be tricky if you think of a lot of these patients being placed on antipsychotics, which movement disorder is a very common side effect of. You can see where that particular symptom may be overlooked, but keeping that in mind and really delving into whether that was present even before the onset of medications. Decreased level of consciousness is something that you often will see. And then there's some other symptoms like autonomic symptoms or central hyperventilation, ataxia, hemiparesis, which occur less commonly, but again can serve as kind of red flags if you see these things occurring. So if we can go to the next slide, please. So take-home point number 1 is going to be that patients with autoimmune encephalitis often are going to present with psychiatric symptoms, and these may be mimicked by mimic schizophrenia or bipolar disorder. And the next slide. And so if these things are present, these should really serve as red flags. So if you are seeing seizures or have behaviors that are concerning for seizures, and you really oftentimes may have to ask, because it may be subtle, are there repetitive behaviors that are actually the patient is doing over and over again that would suggest that they're actually having these types of things. They may not just jump right out at you. They may not be necessarily generalized tonic-clonic. And oftentimes they're going to be more complex partial. Is there cognitive delay? Is there a language regression? Decreased level of consciousness? And much like we saw in Susannah's case, is the neurologic exam abnormal? Is there findings that would suggest that this is something more than just hallucinations and psychosis? That there actually is some other indwelling pathology going on. All of these red flags should then warrant further evaluation. Next slide. So here's the kind of the nuts and bolts in terms of kind of a minimal workup. And one take-home point that we really want to drive home with this is that you don't necessarily have to wait for the neurologist to start this workup. Doing that often will delay the diagnosis, and oftentimes actually those are very crucial days whenever you're talking about recovery. And so the simple thing that you can do if you keep this in mind and keep these symptoms in mind is start the workup for us. So looking at getting serum inflammatory markers, a SED rate and a CRP. You can order serum NMDA receptor antibodies as well as perineoplastic panels. These are actually done through panels through various different institutions, Mayo Clinic being a prominent one, and thyroid antibodies. And so in the NMDA paper, 85% of them actually have positive serum antibodies. So you don't necessarily have to do the LP to get your diagnosis. And so sending that early on in the course oftentimes will be helpful and will help us make the diagnosis a lot quicker. And then MRI. MRI both with and without contrast, looking for evidence of inflammation. This is only positive about 30%, and so it's not the only thing that you can do, and it cannot rule the disorder out. But if it's positive, it's just one more piece of information to let you know that this is not your traditional psychiatric disease. And then strongly consider lumbar punctures with that, and sending the antibodies on the spinal fluid because they do have a higher yield and titers are often higher in the CSF. And then your routine studies. Opening pressure actually is a very sensitive marker for inflammation. So we perform an LPLP, self-count glucose protein, and allelochronal bands, which are markers of autoimmunity as well. Next slide. And so I think this is my last point. Providers should really have a low threshold for looking for these. These are game-changing diagnoses, life-changing diagnoses that you're making that may result in someone either being placed into a psychiatric facility or actually maybe making a full recovery, or potentially even being fatal. So these are life-changing diagnoses that you really need to be aware of and look for. And the thing that's really important is thinking of it early, because these patients can be responsive to immunotherapy. And we see from the paper that was just published that early immunotherapy definitely results in a better outcome. And so the clock is ticking on that. And so you definitely want to be aware and get the evaluation. And so Heather's going to talk about treatment now.
All right, so I take over here. So the cornerstone for treatment of autoimmune encephalitis is immunomodulatory therapy. So these are autoimmune diseases, and they require aggressive therapy. So there are kind of two tiers of therapy that we think about. So the first line therapy is IVIG, steroids, and plasmapheresis. And these have been used both as monotherapy and in various combinations. One thing that's important to recognize is that there are no standardized recommendations for how to treat these conditions. So when you're reviewing the literature, you're going to see variable procedures that are used or treatments that are used, durations, and doses. For patients who fail first-line therapy, it's recommended you proceed to second-line therapy, and that involves Cellcept, Cytoxan, or rituximab. These are big medications, but this is a big disease. So you kind of work up depending on patients' response to therapy. The current recommendations are if patients are not responding within the first 4 weeks to showing some signs of improvement, that you escalate up to second-line therapy. One thing that's important to remember with these diseases is they don't get better quickly. So the average time to recovery is 14 months. And patients will continue to show improvement even 18 months out from their onset of disease. So what you're looking for is initial signs of some improvement. You're not necessarily looking for dramatic return to their previous state. And if they're not showing some initial signs pretty quickly, you want to move up to the stronger therapies, again, because early and aggressive therapy is really what leads to the best prognosis. For some patients with an NMDA receptor encephalitis, they have an associated tumor. In particular, ovarian teratomas have been associated. So removal of those tumors or looking for certain cancers is important, especially in females. But also in males, they can have testicular cancers, and multiple other cancers have been associated with this condition. Removal can be curative, but many of these patients actually require at least first-line therapy to really lead to recovery of their disease. It's also important to recognize you need to manage the other signs and symptoms that patients have. So these patients can be very hypertensive, they can have significant psychiatric manifestations, seizures, and you need to treat with appropriate medications to manage those signs and symptoms. I would like to highlight, though, that just because someone responds to an anti-epileptic doesn't mean this is a primary seizure disorder. Just because somebody responds to an antipsychotic doesn't mean this is a primary psychiatric disorder. These are the signs and symptoms that go with this disease. As you treat the disease, those signs and symptoms get better and you can peel off those medications. But you need to treat them appropriately, not let them sway you from thinking that you have the wrong diagnosis necessarily. Next. So the prognosis overall for anti-NMDA receptor encephalitis is quite good overall. With that being said, there is a 6% mortality rate in the same study that Dr. Galantine was talking about with over 500 patients. Of note, some of those patients never received therapy. Certainly patients tend to do better when they receive therapy. They do better when they receive therapy early and the more aggressive therapy. But there are some patients, despite our best efforts, who do not get better from this condition. That being said, 81% of patients had a good outcome, and they define that as a modified Rankin score of 0 to 2, so with very minimal, if any, disability afterwards. They found that about half of patients responded to first-line therapy, but they also found that in this cohort study, half of patients who didn't respond to first-line therapy did not receive second-line therapy. And part of that, again, comes from the fact there are not standardized treatments for this. So some patients continue to receive first-line therapy because people didn't know what else to treat them with. The other thing that sometimes happens is there's been, in some other autoimmune encephalitis, and also in NMDA, you can have persistent injury from this encephalitis. And so some patients are thought to just have persistent injury, that this is not reversible, and they never get their treatment escalated to second-line therapy. But if you look at patients who are treated with second-line therapy, they had significantly better outcomes than patients who did not receive second-line therapy. So in general, we would say until you can show that this is not reversible, you should be more aggressive in the treatment, because the outcomes for patients, if you're not aggressive, are quite devastating. They did find that about 12% of patients had a relapse within the first 2 years. Patients who were treated actually with second-line therapy had fewer relapse rates, even though you may look at, based on how the study is done, those patients may have had more severe symptoms or been less responsive to initial therapy. They actually did better over the long term in terms of fewer relapses. 2/3 of patients who had a relapse, it was less severe, but in 1/3 of patients, it was actually more severe. Predictors of good outcome, as Dr. Galantine mentioned, are early treatment and moving up to second-line treatment for patients who are not responsive to first-line treatment. So the major take-homes here are that you need to initiate treatments as soon as possible. Be patient. It's a kind of a balancing act. You've got to be patient, but you also have to be aggressive. So we're not expecting them to be dramatically improved quickly, but we are expecting to see improvement. And if you're not moving towards seeing steady improvement, then you need to be escalating your therapy and be more aggressive. The average time to recovery is 14 months, so that's something to be prepared for both as the provider, but also to prepare families for, because these children and patients are severely affected, and it's very difficult to watch this, and we just have to be, expect slow and steady improvements. And then again, if first-line therapy isn't working, even though second-line therapies are intense, Cytoxan or rituximab, those are big medications, they're very effective for patients with this disease, and we can't be afraid to move toward them. And I pass it on.
Well, this is really a unique opportunity in the field of mental health because we can grasp here a new condition and become aware of it and potentially impact positively on the life of our patients and families. So I want to focus on one slide on what may prevent us to be able to move in that direction and focus on our cognitive biases that may be working against us. The first one that I would identify is essentialism. Essentialism is the belief that any entity is defined by its essence. So essentialism as a bias is to view this presentation as essentially medical or essentially psychiatric. And depending on who the clinician is, when they come to encounter with a patient, you may just think that if this is medical, it cannot be psychiatric. And if this is purely, you may think that this is purely behavioral. And that would be a bias that would lead you away from being able to recognize the disease. I think the best way for me, the experience that I've acquired to recognize the disease is to actually focus particularly on the catatonic signs. Because those signs are prevailing across all the autoimmune limbic encephalitis. And we've heard them really well described by Susannah, and they're described well in the literature. The paroxystic agitation, the stereotypical, some of the grimacing that initially may look like seizures but might not be seizures, some of the drooling, the hypertension that might actually be more than hypertension but autonomic dysfunction, the difficulty moving, being locked in your body, suddenly having movements that are repetitive, etc. If you can identify these signs, and then if you can think along the lines of what Bill was telling us and recognize that there are other psychiatric symptoms in those patients. They have hallucinations, they have psychosis, they have paranoia, but they also have neurological symptoms. I think that may help you bridge between these two worlds. The second curse, though, and just to say one thing about the treatment here. So the treatment of catatonia, of course, is to first focus on benzodiazepines. And as you know, you should try to avoid using antipsychotics in catatonia. And here again, you want to try to avoid that because it may murky the picture. And you should really try to first use benzodiazepine as a supportive treatment. But the second bias here is the curse of knowledge. The problem now becomes, oh yeah, I've identified this as catatonia. I'm an expert in my field, I know catatonia. 86% of catatonics are bipolar, or schizophrenics. It just looks like bipolar, schizophrenic, or schizoaffective disorder. This is what it is, and let's just go on with the plan. So there's a curse to knowing too much. where we may think that catatonia is always a psychiatric condition, when it really is not. Catatonia is just a cluster of symptoms that occur when something is really wrong with the brain and the brain is on fire, for example. I just also want to point to another bias here that's important, the stereotypical bias. Unfortunately, 81% of autoimmune encephalitis are going to touch young women. I still believe that there is a big bias against women, and if it's a young woman that acts crazy, then she must have a psychiatric disease. I think we've thought like this for many decades, and I'm concerned that this stereotypical bias may play against our patient. I'm also concerned that he may play against their management. And I'm a little concerned when I read the Japanese literature, where before they move in the gradation and the steps of treatment that Heather just talked to you about, they just actually go for bilateral ovarectomy before they even have the proof of a tumor. So you end up with a young woman with a brain on fire who comes out of it menopause. So I do think that we have to go through the gradation of the treatment Heather mentioned, and we also have to remember about that bias. Bias in treatment of psychiatric patients has always existed, and we are part of it. I think we can move to the final slide, the call to action. I think the first thing we've learned here as a call of action is to really listen to the patient. And it's obvious when we listen to Susannah's story, her effort, constant effort at trying to actually tell us something valuable. And in a way, when this may not be heard, the desire to escape here becomes, life-saving. And I'm not surprised she's made so many attempts to try to run away. I have seen it with many other patients. There's also, I think, a call of action of listening to the parents. The parents are going to be there to help us. They often are going to tell us things that are important. The sudden onset of these symptoms. If we can really listen to them, we may even cue on the preliminary symptoms that are usually infectious-like, that occur for a few days before these diseases will start. Next, I'm absolutely really impressed by the fact that so quickly our child colleagues have put in place this evaluation and treatment clinic, because I believe the evaluation and treatment will require a multidisciplinary team, and this is already an ongoing thing with the clinic you've put in place. Hopefully, adult psychiatrists and neurologists and med-psychists can join you in your effort here. I really think you would benefit from having a team of experts at you that can be called when these diseases are suspected. The Autoimmune Encephalitis Alliance, I think, will be of great help in giving some resonance to families and giving them the support they need. And then we have that fundraising campaign that Ellen Egger has mentioned in honor of Florence, and that I hope we'll see many of us running at that race. There you go. I really wish that you will all feel free to ask questions, in particular to Susannah, and that we have time to answer your questions.
I'd like to ask if there is some specific brain areas. There are specific.
Just talk loud.
Just yell.
Yeah.
There is specific brain areas where the antibodies can connect specifically. For example, in the limbic system, there is a low threshold for seizure, and in this case, the symptoms, the initial symptoms were like bipolar or schizoaffective disorder. So, I would like to ask if the main region is limbic or the region like parietal cortex or frontal cortex.
Yeah, it's definitely limbic. The NMDA antibodies, actually, the receptors are very concentrated within the hippocampus. And so and you can see in animal staining very clear increased uptake of the antibody within the hippocampus. And so it's thought that it's very much the limbic system that's involved with the NMDA receptor encephalitis. That being said, there are lots of other autoimmunity encephalitides that have different presentation for frontal lobe and various different areas. So it's not just that.
In the cohort study of about 500, were there co-occurring autoimmune disorders?
They didn't actually comment on whether there was other autoimmune disorders. I would be willing to wager that a lot of them had autoantibodies to thyroid or other commonly seen autoantibody conditions. Keeping in mind that thyroid antibodies occur in about 10% of the population. So I'd be willing to bet there was probably some crossover there. I think Heather has a comment on that too.
Yeah, and when you look at lupus patients, and they look back actually at patients with neuropsychiatric lupus, they found that in the general lupus population, somewhere between 15 and 30% of lupus patients will have a positive anti-NMDA antibodies, but in patients with neuropsychiatric lupus, over 50% would. And so it's probably in other autoimmune processes, it maybe just called something different in those cases, so not very well differentiated yet.
Well, I would like to congratulate on this wonderful presentation, and especially coming from the patient side, help us to understand much more of the insight of what you guys are suffering. And also congratulate on having this kind of organization that we can promote better care for those kind of patients. One thing I would like to comment, in addition of what I have listed here, is listen to patients and listen to parents. I think it is very important for us, the clinical providers, that we take time to observe what's going on with the patient. Especially nowadays, with the practices pretty overloaded, and then we may not have a lot of time when we do runs. And usually the manifestation of a patient like this fluctuates throughout the day and may even throughout the course of the illness. And we really need to pay close attention to what's going on with the patient. Like Xavier had pointed out, usually those kind of patients who present with mental conditions, if you observe very closely, which may not be observed by the family member and may not be sensed by the patient, or who actually cannot express themselves to us, is we will be able to detect some kind of neurological symptoms that cannot be well explained by psychiatric problem. That really help us to actually grab the condition earlier and to treat earlier. We as the MedPsych group have encountered many of those kind of patients over the years. We definitely see a very gloomy consequence when the patients were not treated earlier.
Yeah, I mean, that's the thing about this disease, is that, just like you said, in the course of a day, you can see a different patient. I know my parents would tell, I don't remember, because again, the hippocampus was affected by this disease, so I don't remember most of what happened. But what I'm told by my parents and family and friends is that friends would come to visit me, and all of a sudden, I wasn't normal by any stretch of imagination, but I kind of best version of myself at that point. I could almost will myself to be at my best. And then afterwards, then it would be a real, then there would be a come down with a very catatonic presentation. But then throughout the course of the day, it would be a different person. So I think that's really an important thing. But in the beginning, it's like it started very subtly, and it didn't send me to a doctor. The actual psychiatric part of it did not send me to a doctor. I had paranoid thoughts. I thought my boyfriend was cheating on me. I mean, like things that people think, I guess. But then I had numbness on one side, and that scared me. I remember thinking, that's a little scary, and so I went to a doctor, and they said, oh, you have mono. I said, you probably have mono, and so then, okay, then the psychiatric presentation became robust, and that became the main thing people were focusing on. To the point where I had seizures, and the neurologist I went to see, like I said before, said it was alcohol withdrawal, kind of attributed that whole thing to drinking too much alcohol. So it was almost the psychiatric presentation was so strong at that point that any other sign was just completely ignored, which is a call to action in terms of taking a look at the whole presentation. I mean, I had increased, BP, blood pressure. My blood pressure was really high. Obviously that test with the clock, but there are other signs that this was not just a traditional psychiatric presentation, but that was largely ignored during that long-winded explanation.
Can I just comment on that too? That I think from the pediatric side, for myself, I'm not particularly good at differentiating psychosis from delirium or things like that. In that sense that the patient could will themselves to do better. In my lack of experience, I'd be like, well, then this must not, if it were really medical, this would be a persistent sign or symptom. And so you have to be careful not to be too overconfident in your skills in certain areas, and to really, this is where the collaboration is really necessary to really help you kind of understand fluctuations or things like that that you would otherwise not.
Hi.
there's usually a question on the form we fill out at the end of this. Can you hear me?
Yes.
No? Okay. It says, will this change your practice after you've attended the grand rounds? And I wanted to say that yes, this will. Silly biological questions, which I'm going to corner Dr. Prudhomme about at some point in the future. I might have to buy him lunch. My question is more for Susannah and potentially for our very brave family members who come here, and I really appreciate that. You had at least 5 doctors giving opinions at the same time. You had friends, you had family. What did they do that was helpful, and what could they have done differently?
Oh, that's a really, so focus on the parents and the support system here. You know, I think they serve different functions. I had a wonderful support structure because I had my mom she's always been very research oriented, and so she was the one taking down the information that doctors would kind of, in my experience, would just talk over our heads using these terms that most people don't understand, but she would diligently write them down and Google them later and try to make sense of it in some ways. That was her kind of role. But then the emotional, being in a hospital for a month, and families have been in much longer, and a lot of the families here have been in, a month is nothing compared to what they've gone through, but even a month, I mean, it really saps your will in so many ways, and you have to, this disease is all about kind of fighting, you really have to continue fighting, everyone has to fight, and I had an amazing support structure in terms of emotionally with my father and my boyfriend and my friends who would come to the point where, they would come every day and visit me, kind of reminding me that that there was still something for me to fight for. I still had, they were still there for me. And so I think that was really important to, on some level, to know that was still being kind of supported and people still believed in me in some way, That is. But I don't think I can answer in terms of what they've done differently that I wish they, yeah, I can answer that actually. My rehab, that was something that I'm so lucky to be here now in so many levels. But I didn't do any cognitive therapy or therapy in general after I went out and when I was released, and I think I think my parents didn't. I mean, at that point I was the 217th person to be diagnosed with this. There wasn't a support structure out there. There wasn't a Facebook page. There wasn't places you could go to kind of relate to other people. So they kind of were like, I think she'll just get better. But I think I think if you have people in your life who have this, I think rehab is important. I think talking to other people who've gone through similar things is really important. So that's something I wish they would have done differently.
So unfortunately we have to end here, but just sort of representing our families, I would like to also answer that question, that each one of us have fought like you cannot believe to get our children the care that they needed, just like Susannah's family has. And I think we're all very aware that our kids are lucky that they have parents who have the resources and the connections and the medical insurance and the families that enabled us to get what our kids needed. And one of the things that I always say in leading child psychiatry here, it's not okay that every kid doesn't get what my kid got, or every adult gets what my kid got. So that really, I think we want to end with that we are the fortunate ones here, and we want to be able to do what we've been able to do for our kids and our doctors have done for us, for a lot of other people. So thank you everyone for coming. We really appreciate it.